that my topic seems rather mundane, though it is a pressing problem for all of us who practice gastroenterology and also for the general physician. Right. Okay. I think one of the main problems that I'm going to have is that I've been given 20 minutes to talk on this subject. So let's get going anyway. The clinical scenario is that we have a 45-year-old gentleman who presents in the emergency room with a history of having passed black stool and feeling lightheaded for 3 days. The stool is black, sticky. Recently, he's had a worsening of his epigastric burning, and he has doubled his dose of drugs without any significant relief of the burning. The clinical scenario is that this young gentleman who's come in with a history of passing black stools and abdominal discomfort has a history of hypertension for 8 years. He takes NSAIDs as needed for back pain and has recently started aspirin. He's in the habit of smoking, and he was told in the past that he'd had an ulcer. He has normal bowel habit, and there is no history of abdominal surgery. Lab investigations show that this gentleman who's come in with black stools actually has a hemoglobin of 9. He has a hematocrit of 27. His white cell count platelets, they are all there. The creatinine is normal. The chest X-ray was normal, and so was the X-ray abdomen. So what is the most likely cause when we see such a person, male or female? But when we see this sort of a person, what goes through our mind is what is the most likely cause for his black stools based on the information that we have. And if we think that the black stool suggests that he's bleeding, where is he bleeding from in the GI tract? And what will be the ideal procedure to confirm the location of bleeding site? Okay? We've also got to rationalize why we think that that is the ideal procedure to do, and what would be the differential diagnosis. So let's attack upper GI bleeding. Upper GI bleeding is, of course, bleeding from the stomach and duodenum. And bleeding from the upper GI tract means you either broadly we classify them into either a variceal bleed or a non-variceal bleed. So the epidemiology of bleeds, upper GI bleeds, is there for you to see. The important thing is that upper GI bleeds have around 10% mortality. So bleeds, GI bleeds, upper GI bleeds are desperately important for us. We know that if you have an upper GI bleed, it is 4 times more common than having a lower GI bleed, and males are twice at risk of developing a upper GI bleed when compared with the female population. What are the causes of upper GI bleed? As I said, we straight away, if you think somebody has an upper GI bleed, we divide them into non-variceal and variceal bleeds. We all know that most bleeds are not variceal. 20% are variceal bleeds. The rest of them by far are the non-variceal bleeds. 80% of upper GI bleeds are non-variceal bleeds. So non-variceal bleeds, how do we go about finding out how many? I think roughly what we know is that if you take peptic ulcer disease, that covers at least 50%, Mallory-wise between 15 to 20%, and the rest are there for you to see. If you look at variceal bleeds, we don't just mean gastroesophageal varices, we also mean bleeds from portal gastropathy and isolated gastric varices that bleed. So what were the causes in India? There was data that was published, and it shows, again, you can see, if you look at the duodenal ulcer and gastric ulcer, we are looking at 43 and 17, which makes it roughly about 60%. So 60% of upper GI bleeds are because of ulcers, 10% portal hypertension, 10% erosive mucosal disease, and 10% Mallory-wise. So 60%, 10%, 10%, that leaves you 10% for tumors and others. This is a diagrammatic representation of what I've just told you. In the interest of time, I'm trying to go through a bit quickly. Now, clinical presentation, hematemesis is vomiting of blood, coffee ground 40 to 50%. Some people with hematemesis and melena, which is why we see melena at 70 to 80%. And hematochezia, some people may have fresh bleed through the rectum. Now, patch of bright red blood from the rectum usually indicates colonic and rectal bleed or even anal bleed. But we must remember that sometimes if people are bleeding heavily from the upper GI tract along with their hematemesis, they may also have hematochezia. That is possible. Now, what about management? Initial assessment and resuscitation, which we all know, monitoring of, and we do the basic investigations, as has already been shown. We take the history, brief history if possible, risk factors, medication, as was important in our case. We have to then localize the bleed. Do we do an upper GI endoscopy? Do we put in a nasogastric tube? And if both of them are necessary, when do we do it? And finally, of course, therapy. We have pharmacotherapy, we have endoscopic methods, and when both of them fail, patients go for surgery. Investigations, again, we may do a whole lot of other investigations. We can do a chest X-ray, CT, angiography, LFT. What about nasogastric lavage? Do we always put in a tube or not? Do we put in a Riles tube just because he's come in? I think this is very debatable. We can discuss it later on. But I must admit that if the person is otherwise quite well and he comes in only with a history of melena, I see no reason to put in a nasogastric tube. And what about angiography? Yes, sometimes you need to do an angiography to actually locate the site of bleed, because if everything else fails and the patient continues to bleed, angiography is the last resort. Now, first let's tackle variceal bleed. Octreotide and terlipressin. I think all of us know that octreotide and terlipressin are both very useful. Octreotide you can use safely. Terlipressin, if the patient is elderly, you may need to use it only in the intensive care unit situation. Octreotide, the patient actually can have octreotide, especially in our country. He can have it even if the patient is not in the intensive care unit. Endoscopic management, it controls bleeding in 90%. In varices, we do EST, we can do a band ligation, tamponade, which is rarely done. And when all these fail, you then refer the patient to the surgeon. Management of non-variceal bleeds, which is something that we see much more frequently than varices. You have pharmacotherapy, and the mainstay is IV PPIs. We start with IV PPIs, then go on to endoscopic management, and finally, if that fails, surgery. Blood transfusion, the working rule is that unless the hemoglobin falls below 7, you don't transfuse. This, again, is something that we have to decide for ourselves. If a patient who comes in with a massive, you know that the patient has CLD, he has chronic liver disease, he comes in with a massive bleed, he comes in with a hemoglobin of 7. Are you happy to sit tight? I certainly am not. I ask the patient, I certainly group and cross-match because I don't know when I'm going to need the blood. And 7 is a threshold that's a bit low for me for people who have variceal bleeds, for non-variceal bleeds. Sometimes I'm quite okay with that. Pharmacotherapy, what was the role of proton pumps? Rabeprazole can be given in boluses of 20 milligrams. Pantoprazole, esomeprazole, you can give any of the PPIs. And the rule is that you're better off giving either boluses 6 hourly or you give an infusion. The doses are there. You continue the infusion for up to 72 hours, depending on what you see at endoscopy. So persistent bleeding from ulcer, you have the beginning of a clot formation. The first clot is a platelet clot. Then you have a fibrin clot. Fibrin comes from fibrinogen. If the stomach HCl, that is, if the acidity is less than pH 4, then you have a major problem there, because what happens is that if the stomach is very acidic, the platelet clot becomes very unstable. If any fibrinogen is deposited on the platelet and the fibrinogen gets converted to fibrin, even the fibrin is dissolved, so you have no clot. So unless you improve the pH of the stomach, you're not going to get anywhere with your stoppage of bleeding. Okay? So the bleeding persists unless you elevate the pH. That is, you reduce the acidity, you elevate the pH. And the critical pH that you need to achieve is pH of 6. Now again, when you start giving PPIs, what happens is bleeding from ulcer beginning of clot formation, you first get a platelet clot. Okay? The platelets first adhere to stop the bleeding. The platelet plug will be very unstable if the pH is 4. The platelet plug will be stable if the pH is 6. Once you've got a stable platelet plug, on that you get the fibrinogen. Fibrinogen gets converted to fibrin, and once you get a fibrin network on the clot, only then, on the bleeding site, only then does it become stable. So it is very important that we achieve the pH of 6 and above as soon as possible. That is why it makes a difference which PPI you are using. Just don't use any old PPI. You have to use esomeprazole or rabeprazole to get the PPI, to get the pH up very quickly. Now, this is what happens once you start using PPIs. The PPI will actually bring the pH of the stomach up. Okay, so here you have pepsinogen, which is converted to pepsin. That is also blocked. So you block every step there. You get the fibrin, which was initially dissolving. Now the fibrin does not dissolve. The clot remains tight. Okay, so PPIs are very important in all upper GI bleeds. The reason they are important is the pH has got to go up from 4 to 6. And it has to go up as quickly as possible. So you continue until the confirmation of the cause of bleeding. In high-risk patients, PPI will decrease the length of hospital stay and rebleeding and the need for blood transfusion. So we need PPIs, and here there have been lots of trials. Everything has said yes, and the international consensus on recommendations on the management of patients with non-variceal upper GI bleed says that use PPIs in all patients. Okay, so does the Scottish Intercollegiate Guidelines Network. It says recommends high-dose IV PPIs in all patients with major peptic ulcer bleeding. Now, here is what we have a huge problem with. A lot of patients who bleed, who have upper GI bleeds, are cardiac patients. They're elderly patients who are, as it is, they are vulnerable. Yet they have, because of advanced age, high burden of comorbidity, and polypharmacy with anticoagulants, ASA, and antiplatelet agents. And a lot of them have pre-existing mucosal defects. So what about these patients? In the cardio-gastroenterology, GI bleeding risk minimization strategies, we must use the lowest dose of ASA, aspirin, for cardiac benefit. The current OASIS 7 trial shows there is no additional cardioprotective benefit of ASA beyond 81 milligrams per day. Okay, but because above that dose, the risk of GI bleed goes up. You can eradicate H. pylori. Some people have not just ASA, they may have clopidogrel and may have an anticoagulant therapy. I think the cardiologist must be certain in a patient who's had a GI bleed that the person needs all three. You can actually add a PPI for gastroprotection, and there is another trial which has quite definitively shown that PPIs will lead to a 66% reduction in upper GI bleeds in patients who are on dual antiplatelet therapy. Right, clinical evidences. IV rabeprazole in boluses is superior to IV omeprazole and IV pantoprazole. You can see the median time to achieve pH 6. Okay, the median time to achieve pH 6 in rabeprazole is 12 minutes. In pantoprazole, it is 5 hours, and omeprazole is 2 hours. Okay? So it does make a difference. As you can see over there, again in the graph, the pH needs to go right up. Right at one end, you can see as soon as you give the rabeprazole, the pH goes right up. It then tends to come down because it really can't maintain the levels there. But before the day is out, the pH is constantly at 6 and above, which is very important. This happens when you give rabeprazole 6 hourly. Before the day is out, 100% of the time you've got a pH of more than 6. These are just trials which are telling you exactly the same thing. Okay? Now, what about endoscopic management? So you start off, resuscitate the patient, start the patient on IV PPIs, and then what about endoscopic management? You can inject adrenaline, and there are a whole lot of other things. I think without talking, I'm going to show you this video which tells you what we can do endoscopically.
One of these techniques In injection therapy, a 25-gauge injector sclerotherapy needle is passed through the working channel of a large, single-channel or double-channel therapeutic endoscope. Injection mediums consist of saline, vasoconstrictors, sclerosing agents, tissue adhesives, or a combination of these. Injections are typically made into the 4 quadrants surrounding the bleeding site. Injection directly into the underlying vessel is not recommended. Submucosal injections of 0.5 to 2 milliliter aliquots are recommended, and multiple injections per quadrant are usually performed. The technique of submucosal injection provides a volume tamponade effect plus possible local vasoconstriction and platelet plug facilitation. The endoscopist should observe the raising and subsequent blanching of the targeted and surrounding mucosa. Injection of diluted epinephrine or saline alone as monotherapy is inadequate and should be avoided. Instead, injection of epinephrine plus saline in a 1 to 10,000 dilution, followed by injection of another agent or combined with contact thermal therapy, is preferred. Thermal therapies use either contact methods, such as multipolar electrocoagulation or a heater probe, or non-contact methods, such as argon plasma coagulation. This animation demonstrates the use of a contact thermal probe. A large 10 French probe is recommended. It has been placed into the working channel of a large single-channel or double-channel therapeutic endoscope. The target site may appear as an active bleeding vessel that is spurting or oozing, or as a non-bleeding visible vessel. The probe should be placed directly over the target site and pressure applied to cause indentation of the targeted tissue with compression of the underlying vessel while delivering thermal energy. This action is referred to as coaptive coagulation, and its aim is to weld the artery shut. Treatment should continue until the active bleeding has stopped, or the protuberance of the non-bleeding visible vessel has been completely flattened. The endoscopist should observe a post-hemostasis depression or footprint on completion of the contact thermal therapy, confirming the approximation and fusion of the superficial tissue layers and the deeper tissue layers. This area then should be irrigated with water through the contact thermal probe and observed for any possible post-treatment bleeding. Mechanical ligation usually involves the application of endoscopic clips. A number of different endoscopic clipping devices are now commercially available. The following animation demonstrates a clipping device for mechanical closure of the underlying vessel. As with injection catheters and thermal probes, clipping devices can be loaded into the working channel of the endoscope. At the site of bleeding, a clip is placed directly onto the visible vessel, with caution taken not to amputate the nipple-like projection. Multiple clips can be successfully placed to achieve optimal hemostasis. Care must be taken not to dislodge previously applied clips. As a rule, when optimally placed, the clips should remain in situ for at least 7 to 10 days before sloughing off. All methods of endoscopic hemostasis have been shown to be effective, so it is recommended that endoscopists use the hemostasis technique that they are most comfortable performing and that is best fit to the appearance and location of the lesion. Emerging endoscopic technologies, such as Doppler ultrasonographic probes for guiding the application of hemostasis therapy and evaluating its success, as well as improved endoscopic suturing devices, may play important roles in future clinical management.
As I said, when having seen the patient, if the patient has we resuscitate the patient, look at the hemoglobin. If necessary, we transfuse. We start the patient on IV PPIs. If the patient has varices, then we know what to do. If the patient doesn't have varices and we do an endoscopy and we see that the patient has a bleeding site, those are the different ways that an endoscopist can tackle the bleeding the bleeding site. The surgical indications are when there's severe life-threatening hemorrhage which is not responding to our management. There's failure of medical therapy and endoscopic therapy, and the surgeons always curse us because by the time we have tried everything, the patient is so ill, the surgeon is always just cursing us and telling us, why have you sent the patient to us so late? But, well, that's the way it goes. Of course, if we find that the patient has a perforation, obstruction, or malignancy, recurrent hospitalizations, those are the other reasons why we may send the patient to the surgeon. Now, surgical management, of course, gastric ulcers, we have the bosses sitting over here. I'm just putting in front of you the list of operations that can be done for gastric ulcer and duodenal ulcer. They're all there. But these are done so little these days that a lot of surgeons now complain when we send the patient for a highly selective vagotomy and things like that. So anyway, now this is the Forrest classification of bleeding. When we do a bleed, it is very important to classify. This is the Forrest classification. That is type 1, which is if it's spurting, and 1B if it's oozing, because the risk of rebleed are very high in these patients unless we do something. And 2 is when the patient is not actively bleeding, but if you see a visible vessel, then the chances of a rebleed are pretty high. If you see an adherent clot, then again the chances are high, but not so high. The rest are, of course, okay. So if we go in and if you see that the patient's bleeding site is quite clear and we see a little brown spot or something like that, or even if we see an ulcer where there is no bleeding and no hematine, then we know the chances of rebleeding when we let the patient go back to the ward are really very, very small. So these are the safe patients. The 2C and the 3 are the ones that we like, but we don't like people who are spurting when we do an endoscopy. So prevention of recurrent ulcer bleeding is if you have an H. pylori, then you treat the patient for the H. pylori. If the patient is on NSAIDs, we ask them to try and avoid NSAIDs as much as possible or cover it with a PPI. If the patient is on a low-dose aspirin, if it's on a primary prevention, then we have to think hard whether the patient really does the patient need the primary prevention. If it's a secondary prevention, then the aspirin has to be restarted. The question is when. Okay, that's a bit debatable, but certainly I think everybody would agree that even if everybody who comes in with a bleed, doesn't matter why the patient is on aspirin or clopidogrel or whatever, it has to be stopped, and then you have to restart. The question is, when do you restart? I think between 3 to 5 days, all of us restart the medication. And of course, idiopathic. The algorithm is acute upper GI bleeding. You come in, if you see an ulcer actively bleeding, PPI, endoscopy, ICCU for 1 day, if you can afford it. Adherent clot, again IV PPI, endoscopy, ward for 3 days. If it's a flat pigmented spot, then then of course you can discontinue your PPIs if you had started that. Okay, and by endoscopy I mean the patient doesn't need any endoscopic treatment. In upper GI bleed, if you see a clean base, no IV PPIs, no endoscopic treatment, and the person can go home. Esophageal varices, either ligate, start IV terlipressin octreotide, and the patient often spends at least a day or 2 in the intensive care unit. If it's a Mallory-Weiss tear, I usually don't do anything about Mallory-Weiss tear. They almost always heal on their own. Of course, you can give some endoscopic therapy, and if there's no active bleeding, most of the Mallory-Weiss tear, by the time we look at them, they are not bleeding, so they actually do not need any endotherapy, and they can all go home. Okay, that's it.
Thank you very much, sir, for giving your expert insight. Now the session is open for question and answer.
Dr. Bose, now as a cardiologist, I have to prescribe dual antiplatelet therapy after days implantation. After days stenting, I have to prescribe aspirin and clopidogrel. Okay. Now, do you think in all these patients, irrespective of the comorbid conditions like COPD, diabetes, elderly people, smoker, you have to prescribe a pantoprazole, a PPI, to all patients who are on dual antiplatelet therapy, or selectively those who are having these comorbid conditions? What is your opinion?
Yeah, I think all patients who have a risk of who have a history of ulcer disease, if there's a history that they had bled in the past, then one is obliged to treat them with PPIs. In the elderly patient above the age of 60, that is what we are told, that above the age of 60, all patients, if they have this or they have other comorbidities where a bleed would be a major problem with them, cover them with PPI. So that is the way we go, PPIs. Now the question is whether they need both. As far as I understand it, I'll wait to be enlightened by you. We are told that if it's a bare stent, it's not a drug-eluting stent, and if the patient comes in not 1 month, say 2 or 3 months after that, then how long you can stop these antiplatelet drugs for is not very important. because if they have gone beyond the 1 to 2 months, they are okay. But if it's a drug-eluting stent, then you really need at least 6 months for them to be on this so that the stent doesn't block. The question is then, having stopped, because we are obliged to stop. If you're bleeding, you come in, we stop. The question is, how long do we stop for? Now, we know that aspirin and clopidogrel, both of them, they have slightly different modes of action, but the action will last for the lifespan of the platelets. Because the way aspirin works, it blocks the COX-1, and once it's blocked, only a new platelet can actually generate thromboxane. That's what I understand. Clopidogrel, of course, it acts differently. It acts on the surface. It blocks the receptor where the fibrinogen attaches itself. And this blockade is also apparently permanent. So you have to wait for new platelets to form. The way I understand it is that if a person comes in with a bleed, and if it's important to start aspirin and clopidogrel, you can start after 3 days. Between 3 to 5 days, all of them must restart their drug, or the stent will reblock. Now, if we can do with one, I think you would prefer clopidogrel. Is that right? Yeah. If you prefer clopidogrel, because the half-life of clopidogrel when it's taken is such that if you take PPI in the morning, because it depends on the PPI that you're using, because some of them would use the cytochrome P50, the same pathway. So there's a degradation of the clopidogrel, which might become less effective. So the way to work around that is to give the PPI in the morning and the clopidogrel at night, so there is no interaction, and the clopidogrel can do its work, and the PPIs can do their work. So as I see it, most of us, when we stop, every patient who comes in with a bleed, the aspirin and the clopidogrel must be stopped at that time. If you do the endoscopy and you're happy that the patient is not going to bleed, for example, if it's a Forest 2C, that the patient is not, there's a little brown spot, or you see no bleeding at all, we are happy to start this antiplatelet drug. And I personally, from what I've read, I personally start clopidogrel before I start aspirin, and then I ask my cardiology friend whether the person really needs both drugs. And if he says, yes, the person needs both drugs, then the patient needs to go on a PPI cover. Yeah, that's the way I do it.
Is it really safer to start clopidogrel because it does hamper the healing of the ulcer? And I think in the gastroenterology, some textbook has recommended aspirin in favor of.
Yeah, I know. In fact, there was a paper which said that if you are given a choice between aspirin and clopidogrel, I would start aspirin because I can do something about the side effects of aspirin, which is give PPIs, but there's nothing I can do about the side effects of clopidogrel. I was swayed by that initially, but I'm not quite sure. I believe that now, because if something doesn't make scientific sense to me, then there's a problem with that. We know that the way aspirin works is that aspirin not only does it block the COX in the platelet, aspirin has an anti-prostaglandin activity which is important for mucosal health. Aspirin also has a direct cytotoxic activity, and it affects the microcirculation. Aspirin on its own, without anything, can cause ulcers and bleeds. Clopidogrel will do nothing of this. That is why I actually prefer that if the patient has to go on one drug, the patient should go on clopidogrel. If the patient needs both drugs, then the patient needs both drugs. But the aspirin at the lowest dose and must be covered with a PPI.
Do you believe that one PPI is better than another?
Yes, I think, yeah, because if you look at the way it's metabolized through the liver, rabeprazole is the best, omeprazole is the worst. Omeprazole is the worst. After that is pantoprazole, slightly better than omeprazole. Lansoprazole is better than that, but rabeprazole is the best.
But we usually use pantoprazole over any PPI.
Yeah, it may be the maybe. Yeah. But if you look at the drug-drug interaction, rabeprazole is the safest.
There is papers also that, but we are believing that, and most of the cardiologists are believing with the pantoprazole. That is the common.
Yeah, I know. But then if you look at the way, you see, I was reading the latest article which looks at all 4 drugs. It looks at rabeprazole, lansoprazole, omeprazole, pantoprazole, and it tells you that you're probably best off using it. What do you think, Ashok? Yeah, so Ashok also agrees. Oh. Yeah, that's right.
I think it doesn't
right.
affect
Yeah.
your cytochrome P450.
Yeah.
It's a different way of
Yeah.
metabolizing. So theoretically, scientifically speaking, it has an edge. Yes, rabeprazole compared to the other drugs, but esomeprazole has a problem because of the omeprazole thing. No, and the second thing is in acute situation, which Dr. Bose has shown a slide that if you use it only orally, and then you know within 5 to 7 days all the PPIs are same in effectiveness, but in acute bleed situation where you need to push the pH quickly, then rabeprazole is the best choice because it raises the pH fastest and can achieve that desired pH of 6 or more than 4 at least faster than any other drug. For these 2 reasons you can. I think also for the gastroenterologist, I think you have to, initially it was omeprazole, then it became pantoprazole. Now it is between rabeprazole and esomeprazole, and ultimately there may be another new drug, with more advantages like dexlansoprazole. So it is like that.
With clopidogrel and omeprazole, the scenario is clear. We are not going to combine them. But with rabeprazole or with pantoprazole, we can combine jolly well with this drug.
Yeah.
With it,
Yeah.
isn't it?
Yeah.
So I think
Pantoprazole also has affect the same P450 cytochrome metabolic. Only
Less,
rabeprazole has a different.
No,
Pantoprazole
less.
also affect, but not to the same
pantoprazole
extent
has
as
a very,
omeprazole.
very little effect on cytochrome.
No, omeprazole is
P450.
the most,
notorious.
notorious,
Yes.
but pantoprazole also is partly,
Maybe partly.
but rabeprazole is practically free from the same cytochrome P450. But theoretically speaking,
To me, concerned, practically, practically all people are same. This is the even the rabeprazole has got slight edge over it. But in practical situations, when you are using in case of combinations of 2 drugs like clopidogrel and aspirin indications, though you will have to stop the medication first, as you have mentioned earlier. So how many days you will have to stop the drug, that is a controversial issue. So there is a consensus that 5 to 6 days or even a week to be stopped the drug and then again restarted. The which drug to be started then also is a controversy. Whether you will start aspirin or in a clopidogrel. But in considerations of the clopidogrel and aspirin concerned, so the clopidogrel is much better concerned. So in that situation you can have this. So in that rabeprazole as a newer generation of PPI. But the thing is that practical situations, all PPI are same. But in case of bleeding situations, you'll have to see whether the pH should be the faster reductions of the or elevations of the pH is to be considered. That is my.
What would you say, sir? No, but still, do you put in stents and stuff, or you look at heart failure?
I've stopped doing all that.
Oh, you don't do all that. Okay. Yeah. No. You see, I know there's a problem, but if the patient is bleeding, we have to stop. We have to stop. The question is how long we stop for. তাই তো বলছি. Yeah, that's what I'm saying.
One, we can take some risk. We can stop one.
একটা বন্ধ করলে করতে হবে, দুটো তো বন্ধ করতে হবে.
Very difficult.
No, because the half-life.
No, low molecular heparin do not have any role. In stent, no, low molecular heparin do not have any role.
দুটোকে
I think we had a very.
বন্ধ করতে হবে. Who wouldn't stop? Are there people in the audience who wouldn't stop both in an acute bleed if somebody is bleeding like a pig?
That is the problem. That's why we are facing these problems most of the times.
So, what do you want us to do?
See, the thing is that suppose the patient had the stent 1 month back, so still there is no endothelialization over the stent. We cannot stop both the antiplatelets.
Not even for a
now
day?
Patient is having some GI bleed.
Not even for a day.
No, I think,
excuse me. For a day it is not going to cause any
We
change.
want to stop it for a day, 2 days, 3 days maximum. We don't want to stop it for 3 days.
I think we have ESC papers, ESC, the European Society, American slightly different. ESC has been a bit clear this aspect, as you said, for a bare metal stent, if it's like 1 month after bare metal stent.
Bare metal stent we are not using nowadays. Very rarely we are using. So that discussion doesn't come.
I think this discussion is important. If the patient has a history of upper GI bleed, you will definitely put in a bare metal stent. In that case, there's no issue on that. Over the drug-eluting stent, if there's a drug-eluting stent,
you see. No, that is all right. Remember that statistically 80% of the cases, 90% of the cases we are using DAS, not BMS.
That is the ESC which I'm saying, which I mentioned bare metal and DAS. When it's DAS, they have even said for 3 months, you have to stop. In the case of an upper GI bleed, you have to stop 2 medicines. We are, when there is a bleed, an active melena or a bleed, you have to stop, but you have to remember with this 4 to 5 days period, you can't have antiplatelet for 5 days. So, and then you start on a single antiplatelets. That's just
Start on what?
Either of them, either aspirin and clopidogrel, depending on what your choice is, because there's not clear evidence on any of them. And even as close as 3 months after a death, that's what the ESC has said. The ACC is putting it 6 months, as you said.
Yeah, that's right.
I think we had a very good...
All that data is there. When I was talking, having looked at all that data. That's why I was telling you all why I said what I said.
I think we had a very good interactive session. So in the interest of time, we will conclude the session here.
Another question, please. Can atrophic gastritis bleed? If does it, how we are going to manage?
What?
Atrophic gastritis.
Atrophic gastritis is unlikely to bleed, actually. If atrophic gastritis, I've never seen it. Do you see atrophic gastritis bleed? No. Congestive gastropathy bleeds, for whatever the congestion is from. Congestive gastropathy bleeds, erosive gastritis bleeds from whatever cause, but atrophic gastritis doesn't really bleed.
It is there. When parietal cells dry up more than, less than 25%, then atrophic gastritis occurs.
No, I'm not saying that it doesn't occur. It occurs, but it doesn't bleed.
It is like just alcoholic gastritis. You have got chronic gastritis. Here parietal cells dry more than 75%. And there is alkalinity actually.
I think we would conclude the session here.